Professor Tai, yesterday during your plenary session, you spoke about the genetics point of the metabolic syndrome, not focused on the genetics per se, but you alluded to some genetic defects in the metabolic syndrome. Would you like to elaborate on that?
Well, I think the points that I was trying to make are the following. I think tremendous strides have been made in identifying new genes or new proteins that may be involved in the genetics of each of the features of the metabolic syndrome. I think we need to think a little bit more carefully about looking at these features in isolation. We do know that many of these features are linked pathophysiologically, and therefore we may discover a little bit more as we begin to look at them together. I think we also need to try harder to exploit the findings of these genetic variants. What's becoming clear from the genetic association studies is that if you're looking at common variants for most metabolic traits, these common variants have small effects. And these small effects do limit our ability to use them to understand in great detail what the mechanistic basis of the associations observed are. I think there are a lot of efforts going on around the world to try and tackle this. Many of them involve sequencing to find sort of less common variants, which we can then sort of study individuals who carry these rare variants, where we anticipate the effects to be much larger in much more detail than we have done in the past. And we think that this will provide an opportunity and also sort of proof of concept that targeting these particular molecules would be a useful strategy for the treatment of various features of the metabolic syndrome, either separately or together. It's hard to tell at the moment.
Right. And in terms of not just Australia, but the Asia-Pacific region, what strides are being made in this field? Say maybe within the next 5-10 years, what area is it going towards, do you reckon?
I think the thing that's really changed genetic association studies has really been the genome-wide association study. We now know that the genome-wide association studies do enable us to identify new proteins and new variants associated with many chronic diseases. And there's been a tremendous amount of focus on diabetes, dyslipidemia, hypertension, obesity, all of which are features of the metabolic syndrome. I know that within the Asia-Pacific region, there are many groups involved in doing these genome-wide association studies. One of the things that is happening within the Asia-Pacific region, and I think the most important thing that needs to happen in the next 12 to 18 months is for these groups to get together, pull their data together, and see what they have as a corporate body rather than as individual studies. And the reason I say this is because by and large the observation has been, as I've mentioned, that common variants have small effects. Most of these studies are underpowered, and only by combining data and combining resources will be able to find things that are truly associated with the disease and actually involved in the biology.
We talk about research. What about in clinical practice? What are the challenges that clinicians are facing in terms of identifying metabolic syndrome in patients? Do they use the waist circumference parameter? Do they look at obesity in a wider scale and not just saying you're obese and therefore you do not have the risk of diabetes, you have the risk of cardiovascular disease, say? Do they look at metabolic syndrome as a disease entity?
I'm very careful about sort of classifying disease entities, and one of the things that we have to remember that when we talk about disease, particularly with metabolic traits, what we're really talking about are people at the extremes of the normal distribution of the trait, and that just means they are normal, except different from the rest of the population. So I don't really like to think of it as a disease. I'm not convinced at the moment that giving it a name or calling it a disease is particularly helpful from a clinical perspective. I think it's very important when we think of the research perspective, because I think if you try and think of each of these factors in isolation, then you get lost. and you forget that they're biologically linked. In the clinical perspective, I think there is a role for thinking about the metabolic syndrome. And that role, the most important role that it plays, is to remind us that people with dyslipidemia, obesity, and hypertension and diabetes should be treated in one place. And in that sense, there are many places you could go, or many institutions you could go to, where they'd have an obesity clinic or a hypertension clinic or dyslipidemia clinic or a diabetes clinic. And you might think that maybe that's not appropriate, given that all these things tend to occur in the same person, and that you need to take a global view of the whole thing. The other important reason for thinking about the metabolic syndrome is, even though I alluded to the fact that obesity is not absolutely critical, people can become insulin resistant even in the absence of obesity. They can develop dyslipidemia in the absence of obesity. It very often is part of the syndrome. And therefore, that tackling the lifestyle modification that reduces obesity will tackle many aspects as well. And that's yet another reason, I think, not to try and divide up patients or clusters of diseases into individual sort of tracks. So to my mind, that's the most important thing. Now, whether that requires you to say, well, you've got the metabolic syndrome or you don't have the metabolic syndrome, I'm not sure.